Excuse me, that was an error over here.
Hey folks, if you are listening in on YouTube or watching the YouTube recording, you are behind the curtain with our incredible panel right here of experts.
Excuse me,
We're
that
just
was an error over here.
Hey folks, if you are listening in on YouTube or watching, all right, there you go. So we're just getting ready to get started. We're going to get started in about 60 seconds. Put on your phones on vibrate if you don't mind. Even vibrate near your microphone could be disruptive. So just be wary of that. There is a chat that you could communicate with me and Cherry on. Just be really careful about not sending it to all the attendees. So if you click on chat, you can see how that works. It defaults to all panelists, that's fine. But just notice there's an all panelists and attendees. You don't want to do that. And you could go individual to each panelist as well as the co-hosts, which Sherry and I should be listed in your pull down menu. Sound good? Okay. All right, folks, I'm going to get us started in, just going to click a few buttons, make sure that I don't have any pop-up windows on Outlook going in the middle of this. And we are going to rock and roll. All right, countdown 3, 2, and 1. Have fun, everyone. Greetings, everyone. This is Eric Glazer. Welcome to our live recording of Bright Spots in Healthcare, produced by Shared Purpose Connect. We bring together leaders to not only inform you, our audience, but most importantly, unearth successes, bright spots at health plans, at hospitals, at medical groups, at various other healthcare organizations around the country. Our goal is to identify as many bright spots as possible so that you, the listener, can determine if those bright spots shared today during this episode can be applied at your organization or at least reshape your thinking at your organization. We believe that this approach of finding a bright spot and cloning it is the best way to improving healthcare in our lifetime. If you are not yet a subscriber of Bright Spots in Healthcare, what are you waiting for? Go to your favorite podcast app, search for Bright Spots in Healthcare, please subscribe. Please give us a rating of 5, maybe even a comment for your fellow potential listeners about the show. This is the best, most effective way more and more folks in the healthcare industry could find the show and take advantage of all the bright spots that we are able to bring to you each and every week. Our topic today is an incredibly important one, and I believe pretty confidently that it's going to be a huge topic in 2021. We are just hitting it early. It is called the super determinant, the digital divide, and we will discuss both how to identify some of the root causes of the digital divide and then solutions to drive better outcomes. Per usual, we have brought together a superstar panel for you. A hat tip to our senior producer, Sherry Keels, who is so instrumental in producing this great content for you. To save time, we've emailed you their bios. We're also going to post them in the chat. If you are listening to this on a recording and you want to check out the incredible qualifications of the 4 experts you're about to hear from, you can go to sharedpurposeconnect.com, click on recording, and there'll be a list of all of our shows. And next to each show is a link to the bios of our roundtable experts. So you can read up on all of these folks as you're listening to the recording. Okay. We are able to provide you programming each and every week due to the incredible support we receive from all of you when you show up. I know we don't charge you, but your participation enables us to handpick organizations to both financially support the program and also provide unbelievable content and add to our discussion. So I want to thank Revel Health, who's our sponsor today. They're one of our awesome partners of the Bright Spots in Healthcare show. They've been with us for quite some time. We love working with them. You've heard me talk about how we have a big echo chamber in our industry, and we need to often look outside of our lane to come up with new ideas, to come up with bright spots. When you think about important issues that we all grapple with, like engaging the consumer, you should be looking at companies like Revel Health. They are doing things unlike traditional healthcare companies. They're actually taking a very individualized approach to population health. I'll tell you more about what they do later on in the show. Sara Ratner, who's on our panel today, is one of our most frequent guests and one of the most thoughtful and smart healthcare strategists in the industry, and along with doctors Alli, Ramsetty, and Rodriguez are going to provide you with a lot of insights and thought-provoking ideas on how to best bridge the digital divide for your population. So let's get to it. I want to, Sara, since I already talked to you, I'll bring you in first and just for everyone, set the stage of how you define the digital divide.
Sure. Well, it's important to put out a definition to level set what we mean around this. So at a very high level, it's the uneven distribution and access to and the use of technology and the internet. And this impacts many different areas these days. We see it all the time, but especially healthcare with the increased acceptance of telehealth. However, it's not only the hardware and the technology, but it's connectivity and the literacy that is associated with accessing it as well. So we've studied this in great detail, and there's a couple of interesting facts that I'd throw out there. So first, 62% of the counties in the US don't meet the government requirements of broadband access, the bandwidth that's necessary. That's, to me, shocking that this is the United States and we still do not have the minimum broadband speed to serve our communities. Also, FCC research has recently shown that many rural communities with the highest diabetes prevalence also have the lowest broadband access and the highest obesity rates that are 6 to 10 points above the national average are in areas with low broadband access. So we know this is a massive issue that impacts healthcare. And so this is why we refer to it as a super determinant of health, because it really is a limiter in accessing healthcare. So as plans, providers, and social service organizations work together, it's absolutely essential to take an individualized approach in addressing this. And so for us, the first step and critical to this is the microsegmentation before you even create the solution. And when I talk about microsegmentation, it's really understanding at an individual specific level the variables that influence health action. And it's the lens through which we need to understand and engage in individuals. And every area is different. Recently, we're looking at different trends in internet access, and we looked at a specific area in Louisiana, and it was in the city 2 blocks apart. And the 2-block difference in internet access was astonishing, with one not having the rate of no internet access was 5%. 2 blocks away, it was 15%. And then that also corresponds to people's response rates with different types of things like surveys and getting back to the doctor. So it's in developing techniques in order to start this, it is absolutely critical to break things down in the most granular way. And while it's can be tedious and difficult, in order to get on top of it, that's the way we have to look at it.
A quick PSA, we have a Q&A module at the bottom of your screen. We have a fairly sizable live audience right now, so I just ask you the favor of using that to ask your questions. I think we'll have time to get to a bunch of your questions today, so feel free to ask them, and Sherry and I will kind of incorporate them into the conversation. But don't use chat for the questions. That's a really important distinction because we'll lose sight of the questions through that thread. So much better in the Q&A module. So thank you in advance for that. I'm going to bring in Dr. Anita Ramsetty. She is the medical director and faculty advisor of a really interesting clinic down in South Carolina called CARES. She's also the director of student services learning at the College of Medicine at the Medical University of South Carolina. So Anita, can you talk about first, how are you doing things a little bit differently at CARES since the pandemic? Maybe even like a quick 1 minute on CARES, then how are you doing things differently since the pandemic as it applies to the application of digital platforms?
Sure. So a little bit about CARES clinic itself. CARES Medical Clinic is actually a student-run free clinic. We may have some listeners who are also involved in student-run free clinics at their own institutions. And to all of us involved, we know exactly what this means. It means that there is little to no funding. So CARES generally runs on a shoestring budget. Almost all of our patients are uninsured. So we have three main sites. There's a main clinic site where we see all uninsured adult patients 3 nights a week. We also have a rural outreach that sees, again, largely uninsured patients, although that group tends to skew a little bit older than our main site. The rural site tends to be above the age of 55. The main site really truly falls probably between 18 to 45 or so. And then we have a pediatric immunization clinic that runs every few months, which of course is all pediatrics and very different, but still largely probably about 98% uninsured children. So all of our patients lack insurance that would typically cover a lot of visits and a lot of other things. And that's sort of the basis of who we see, that's who we serve. So when the pandemic hit, all of our services were disrupted, as you can imagine. All of our staffing is volunteer. We have very few people who are actually paid on staff. And then we had patients who were already sort of barely hanging on, now having even less access to everything. So we tried the phone first. We tried the most accessible version of tech that our patients have. And as all of you know, telehealth applies to really any format where you can synchronous or asynchronous communicate with your patients. So a telephone was worthwhile, and many of our patients have a telephone. So we tried that first. Some visits worked great by telephone and some didn't. But we were able to at least stay in touch with them that way and make sure that they continued to have care. About a month after that, we rolled out the Telehealth Platform. And so currently CARES runs both care through telephone as well as the DoxyMe platform so that we can see patients live if they have access to a screen, a telephone, a smartphone. And we're now back to seeing people in person. The important thing that we found out, it wasn't so much that we didn't know this necessarily, but it became even more apparent that even with the forms of technology that some of our patients may have had, there were still other barriers that were the issue. So for instance, the telephone was the first thing we used to reach out to our patients. Turns out many of them don't have consistent use of a telephone. They don't own their telephone. They have paid telephones that run out at the end of a month. So if we happen to catch them in between when the telephone had money on it and it didn't, we now could not contact them. So we had issues like that. We found out that many of our patients may have had a smartphone, but they don't know how to use a platform built for healthcare, as opposed to perhaps buying something or playing games on it or something else. All of the other reasons we have smartphones, still being able to actually use a phone for a video conference to telehealth with your provider is different. And that was a different skill set that many of them didn't have. So for us, even dealing with a population that had many other issues in terms of access to healthcare, we found these other subsets that really contributed to how equitable it was for them to even use a platform of any type when we were able to try to reach out to them.
I want to, before we get into sort of hardcore solution talk, I want to bring in the CEO of a medical group, a multi-site medical group in Trenton, New Jersey, called Henry J. Austin Health Center. And to do that, the CEO, Dr. Kemi Alli. Kemi, how are things being done differently right now in Trenton?
So good morning, everyone. Yes, I would say our experience resonates with the CARES clinic. So at Henry J. Austin Health Center, we are a federally qualified health center. The majority of our patients are 200% or more below the federal poverty level. So a really significant proportion of our patients are impoverished. 1 in 9 of our patients are homeless. About a third of our patients are Latino, and a significant portion of those individuals are undocumented. So again, you can see we've got a real complex makeup of individuals, our demographics. that are impoverished, that are undocumented, that are homeless. And so we struggle with a lot of the same issues that Dr. Ramsey just mentioned. Very quickly, we realized too that in the height of the pandemic, we wanted to make sure that our patients could have some degree of access to the services they really need. So we too switched to telehealth, telemedicine. We also use DoxyMe. And what we saw, we were surprised that many of our patients did have a telephone and actually did have a smartphone. And that's probably because we're in Trenton, New Jersey. We're in a really inner urban city. It's the capital city of New Jersey. And so a lot of individuals did have a smartphone. And then for those that didn't have a smartphone, many had an older flip phone. So about 80% of our patients had either a smartphone or at least a telephone. So like was mentioned before, we did realize that a significant part of that population with a smartphone still didn't quite know the other capabilities that you could do with it. So didn't know the telemedicine platforms. And so one of the things we instituted was working with our community health workers, our patient navigators, and they would call the patients ahead of time. They would reach out to them ahead of time and actually handhold and walk them through the process, show them how to log in, show them how to use the video, show them how to ask questions, et cetera, and found a lot of success with using our community health workers in that way. And then for those individuals that didn't have the technology, they didn't have a laptop, a smartphone, or even a regular phone, we instituted telehealth kiosks within our center. And so that way patients know our centers, they could still walk in, they would go right to an exam room and someone would help them set up so that they could still, through our internal systems, telemedicine with a nurse or the behavioral health counselor or a provider. And so using those two methods, we had quite a good bit of success in making sure that our patients had access to the services they needed.
Great. Questions are coming in. Julie, I know you're in the audience, so you can't talk. Please let me know if that answered your question. I think it might have proactively gotten to most of your question there. If it didn't, please kind of specify where you want me to go and I'll bring it up later on. Okay, let's talk about how you go about, we've already heard the fact that, broadband data plans, phone plans in general are a big issue, but how do you go about anticipating other root causes behind the digital divide beyond devices and phone plans? Anita, why don't you go first? How are you guys looking at that?
So Kemi and I think had a shared experience where we realized, even if you have the phone, it doesn't really necessarily translate into knowing how to utilize it for this purpose. So I think that was the first thing that jumped out where we thought, this is going to need some teaching, not necessarily that unlike handing a glucometer to a patient and saying, hey, now you need to start checking your blood sugars. Well, they might be able to figure out a couple of the buttons, but to track it, to do those other things that you might want requires some teaching. So I think that was one of the first things that jumped out where we thought, okay, access to the device and access to broadband does not necessarily mean access to telehealth. They are not the same thing, even if you have the equipment. So education was still necessary, support was still really necessary. And for, I think, probably many of our mutual patient populations, what we found also was that there was some degree of skepticism, and we learned quickly that we had to really, really work on building trust with our patients. On looking at this more broadly, I think it's beyond only our very underserved patient population. It's possible that it's more of a problem for ours, but there's a paper that I'm hoping that we'll be able to share with everybody that interestingly was called Do Patients Trust Telehealth? It came out in 2015, and it may be different now, but 5 years seems like 10,000 years at this point. This year is so long. But at that point, when they asked patients, would you trust a diagnosis that comes by telehealth? about 75% of all the people, if you add them up across all the age groups, had some degree of a negative answer. The highest percentage came from people who are over the age of 65. And if you think about our aging population in this country, that's really something to pay attention to. So first, we have the issues of access broadband-wise, then we have the devices, and then we have the knowledge. But even if we fix all of that, there has to be some degree of trust in your healthcare system and your provider. And that is at the core of all of our relationships with our patients. So I think as providers, we know this. And if we are now in a situation where the technology might be a little unusual and the access is unusual and they don't trust the diagnosis, that's really a problem. So what we've been doing, particularly for our patients, is we've been asking lots of questions and doing a lot of listening on individual basis, on small group versions, and trying as much as possible to encourage trust in the system. And what I have found, at least, is that in part that also means really disclosing the shortcomings. So for instance, for some reason, over the earlier part of the pandemic, we had several patients call in with complaints about a new rash and new ear pain. None of those are easy to diagnose with a conversation or even looking at it over video. And it was really at that point where you had to say, I'm really sorry, I cannot accurately diagnose this over the phone or over the video. I need good, appropriate healthcare. I can't see the rash. And I think our patients appreciated that instead of being told, this is what we think it's probably going to be, and this is the best we can do. So for us, it's been a combination of a lot of support, similar to what Kemi brought up, of walking them through, trying to figure out where the holes were, either in knowledge or access, but also really working on building trust for our patients so that they understood no matter what the platform, we would be honest with them on both the strengths as well as the shortcomings. And we would still try to get them care, however we could do that.
Let's bring in Dr. Jorge Rodriguez. He is the health technology equity researcher, and he's also a hospitalist at Brigham and Women's Hospital in Boston. How are you guys in Boston? How is the Brigham looking at anticipating root causes? Is it similar to what they're doing at CARES, or is there some different approach?
No, thank you for having me. I think it's a lot of the same themes, and I'm excited to hear sort of similar experiences across the board. I think the way I've been thinking about this is we've been sort of structuring this in a sort of a hopefully easy to remember way, sort of the 3 A's of digital health equity. And on the first A, really focusing on access, which we've talked about a lot about internet access, broadband access. And in terms of, there's a lot of great kind of solutions to those. I think that, up front, and just to kind of like, say what's important to do, I think the big thing is like screening, which it sounds like my co-panelists have been doing. Just like we're screening for other social determinants of health, you have food insecurity, you have housing instability. What's your technology access like? And then being able to report out those metrics as an organizational level is really important for us to be able to make that a change. One example that we've had is that, especially as a hospitalist, discharging patients, I've assumed that they have a discharge appointment, and to some extent I've been like, oh, as long as they have a discharge appointment, we're all good. But what if that's a virtual discharge appointment or a telemedicine discharge appointment? I don't know if they have access to the technology or not. And so that's sort of impacting continuity of care. So I feel like if we include some of the screening access pieces early on, just part of standard care, it really goes towards, and we sort of have a pilot going, trying to get that going, to understand that and be able to report out at an organizational level. I think that the other component to this, the second A, is all around adoption. And we've really sort of focused on some key pieces of it, digital literacy being such an important piece, that sense of trust from patients as well. I think the other things I'll add that we can really advocate for are sort of the usability pieces. I think as a healthcare system, we don't have to feel reliant, like whatever tool we got, this is what we have to make do. And when we have to, I think there's an important collaboration that needs to happen between healthcare systems, clinicians, and the vendors, the telehealth vendors, whichever one that is, to be like, hey, you've developed this very complex system. My patients can't do that. We're not serving them right. And I feel like we shouldn't just be like, well, we have to it's on the patient. We have to teach them. This is it's multi-level. So we really have to engage the vendors and saying like, can we iterate on this a bit? This is not like, there's some good work to be done here. I think that's a key piece of it in terms of adoption. The other thing I think is really sort of, it's workflow. So much of this, we talk about the tech aspect of it, but a lot of this is around workflows. And one of the kind of key examples that I like to think about is sort of the third party or the interpreter workflow. For our limited English proficient patients, that's such a key component of the way we deliver care. And a lot of these tools make it a big challenge. And I know that's it's a work in progress and we're working on it and we sort of had to switch, but I think establishing those clear workflows are not only important to the way to care, but get you clinician buy-in, right? A clinician, as soon as you start putting up workflow barriers, you have to click here, go there. It's confusing. I have 15 minutes to see a patient. If I have to spend the first 5 to 10 figuring out how to bring in a third party, you're not going to have buy-in, right? That's the sort of peak that we've seen in telehealth. It's going to quickly go back because the systems are just not there. And then I think the other thing I'll say in terms of the third A is around assessment. And I think there's two components, at least for me, to assessment. One of them is around looking at an organizational level, maybe even a national level, not just this binary sense like who's using telehealth and who's not. What do those patients look like, right? I think in the quality and safety world, there's increasingly this push towards looking at patient demographics across things like catheter-associated UTIs or kind of these quality metrics that we look at. We want to look at who's experiencing those things. Similarly for telehealth, who isn't using telehealth? What do those demographics look like? Who's using the phone visits? What do those demographics look like? Who's using video visits? And what do those demographics look like? And should we report that out, especially when we're talking about like the CMS? Should we report that out at a national level to really make these like bigger changes to, if we're finding that most of our patients of a certain demographic are using a telephone visits, is there a push for things like policy changes like universal broadband and pushing in that direction, so that it's not left to the healthcare systems to say, I need to figure out how to connect my patients. This is just, if it's really a social determinant of health, we should make these larger social changes. And the last thing I'll say is really around looking at this as, our ultimate goal here, and I think my panelists will agree, is really around health equity, right? Like my goal is not really, to some extent, my goal is digital equity, but it's really as a vehicle to get to health equity. So I think just making sure that we're assessing and checking the effectiveness of these tools, because we've kind of picked them up very quickly because we had to, but making sure it's getting us to the ultimate goal of, what Sara was talking about, a lot of the diabetes outcomes, making sure that using these tools, we're improving those outcomes. So I think those are sort of the kind of the 3 A's and the things that I'll mention.
Quick follow-up. You mentioned health equity. We ran a session on health equity about 3 weeks ago. And incidentally, this topic at today's session was a spinoff based upon the attendees' feedback to cover this topic directly. And so that's a reminder to me to let everyone know that in about 15 minutes or so at 12:15 East Coast time, you'll receive another email from me asking for your feedback on today's show. And it includes specifically other topics we should cover as we carry out the rest of the year, moving in 2021. So I thank you all in advance for taking it. It takes about 2 or 3 minutes to complete, and I will send you multiple emails if you don't complete it. So I thank you in advance for that. You mentioned, Jorge, access, adoption, and assessment. And when you were talking about access, you'd alluded to that you were starting a pilot. Do you mind telling everyone very quickly what the pilot is about and how you're going about it in case folks want to learn and maybe even clone that idea?
Sure. So the pilot we were looking at with my colleagues, Esteban Gershanek and Catalina and Dan Kavanaugh, is really looking at on the inpatient side. We just realized that as we were discharging patients from the hospital, we were assuming they had a discharge appointment and not realizing that what kind of appointment was it? Was it virtual? Was it in person? Was it phone? And not having a sense. So part of our pilot is just starting to include that as part of our conversations. When Catalina, one of our admins, helps arrange discharge appointments. So just including that as part of her workflow, asking patients, hey, do you have, like, kind of going through those questions and making sure that the patient can not only like, here's your virtual follow-up appointment, but like, will you be able to actually make that appointment? Because it doesn't matter if you have the appointment listed, if in the end the patient's gonna be like, I can't access that. So just taking more of a send there, and they're down the line, there are other, and the clinics are doing this same thing to make sure, but we just wanted to take an active role as we're discharging a patient to make sure that, like, hey, we did our part to make sure they were able to make their follow-up appointment. So we're just starting a pilot to just understand where our patients are with the hopes that we'll then be able to then offer them some of the services that Anita and the rest of the group have talked about.
Great. So it's a reshaping of the questions you need to be asking upon discharge. So it's really changing your diagnostic tool, if you will, or your discharge tool to be asking the right questions and creating a process around that for everyone to follow, if it's effective.
Right, exactly. Yeah, just part of that theme of like, if we're treating this as a social determinant of health, one of the models that we often have for social determinant of health, we screen for them and we refer to a resource. So applying that same kind of thought process to technology access, if we're making this sort of like a central part of care, I think it's important to do that.
Okay, and then this is why it's so great that we have such a great audience. So we have a couple of follow-ups for you. So you're measuring obviously digital equity and health equity. Could you share with us some of the key performance indicators or even some of the leading indicators you're looking at to recommend, that you're recommending, that you could recommend the folks to follow if they're going to come up with a similar initiative?
Yeah, I think for this initiative, we're sort of early days. We're just sort of doing screening early on. I think speaking more broadly, I think it's just, looking at, to some extent, you don't have to change your key performance indicators too much in terms of your healthcare outcomes, right? If your ultimate impact is to say, I'm going to improve the care of patients with diabetes, checking in on their A1C levels if they're primarily getting their care through the virtual setting, making sure they're getting their screening, right? One of the things that we do with a lot of folks with diabetes, like Anita was mentioned earlier, was sort of like, making sure their blood pressures are getting checked, their lipids are getting checked, they're getting their eyes checked, they're getting their feet checked. So all of those things are really tough to do over a phone or video. And so I can chat with you, I can help you titrate medications, but if you don't have an at-home blood pressure cuff or a blood pressure cuff anywhere, like how am I going to be able to do that? So just making sure that having the visit and having access to care remotely is one thing, but there's so many things that we need to do. You just need, laying of the hands, as we say, to be able to get these things done. And so I think I don't think that we don't have to reinvent the wheel. I think just looking at the similar metrics, just making sure that if patients are really relying on the virtual care, we're sort of, meeting the metrics that we've already established is what I'd say.
Okay. And you don't have a written model that, you've put together that you're able to share, right? That's another one of our guests are asking.
A model in terms of like what to look at, or
or just even the list of new questions that you're proposing in your pilot. Is that public information? Would you be willing to share that, or
Yeah, I'm happy to share the questions. There's also I can share a few different resources. We sort of collated from a few other resources of other kind of like tech literacy. So I'm happy to share those resources with the group.
Maybe we'll what's the best way of doing that? I guess we'll just send it in our follow-up email. Sure, if you can make a note of that, we'll follow up with Dr. Rodriguez and include that in our follow-up to folks. And if you want, let's do it that way. And do you want us to, you'll tell us offline the best way folks who want to contact you, and maybe they have feedback for you too. Who knows? Maybe you get some product research out of this.
Happy to chat.
So thanks for that. Let's talk about creating a more formalized process to help organizations and practitioners create a more, I would say, a personalized approach to digital care, so to bridge that divide. And I'll bring back Dr. Anita Ramsetty to talk about what are you guys using at CARES to fundamentally decide, what does Eric need, what does Jorge need, and are there differences in our needs? What does Kemi need? Do you have a diagnostic tool for that?
So I get dibs on contacting Jorge because he's working on something that we're sort of working on as well. I call dibs on this. So what we're working on here, we haven't implemented it as yet. We are trying to develop what we've sort of nicknamed the digital vital sign. It will be similar to what is currently referred to as the hunger vital sign. Some of you may know what this is. It's a 2-question validated screener for food insecurity. And that was developed and validated based on a much larger document that was used to screen for food insecurity. But it's only 2 questions, and it actually is quite useful for screening for patients. So we're starting from the ground up, which is why I'm going to be contacting Jorge after this, because what we're hoping to do is to develop a tool where we can screen and apply this to everybody, probably on an annual basis as a screening tool, but encompassing all of the aspects that go into what we think of as practical digital and tech literacy. So there are other tools out there. For instance, there's a scale called the eHeal scale that really measures electronic health literacy, but it's more geared towards patient comfort level and knowledge in terms of looking up and finding appropriate health information on the internet. But it doesn't necessarily address use of a device and what this actually means, trust in the device, accessibility of the device. So what we're currently building with our research team here, and the we I refer to is actually a colleague of mine who wrote a paper with me earlier this year on the digital divide. She's the director of our 529 clinic, which is a clinic for individuals who are housing insecure. So between our clinic, CARES clinic, and her clinic, we have a lot of patients who overlap and who have the same limitations. So what we're looking to develop is a scale that really measures a couple of those factors that are important. Knowledge is one, access is another, but access also needs to include the stability of the access. So as I mentioned, some of our patients have access to a phone this month and not next month, and that has to be taken into account. We want to really find out the usability and some way to rate that. The way I think about that is, for instance, for my patients who are given prescriptions for insulin pens, sounds great for those of us who can dial something up and inject it. But if you have manual dexterity issues, then this is no better than me handing you another device to give yourself insulin. And you have to know that when you're trying to ask someone to use an actual device. And then the last part of that is trust. So we're trying to develop a larger survey, get that validated, and then shrink it down to something that is relatively quick, because as Jorge also mentioned, workflow is critical. If you throw out a 50-question survey, providers don't have the time to do this, patients will not answer it, and then it's pointless. So we're at the very beginning stages, but we're hoping that we come up with this very useful digital vital sign that we can use for all of our patients. And based on that, either as a rating, a score, a level, or otherwise, we can then come up with a menu of options for both how their access to healthcare is appropriate, as well as what can be done. It could be that you find out, oh, we just need to refer this person to a community-based specialist who can spend an hour with them and teach them how to use the device they have, and we're good to go. It could be this person needs a referral to OT so that they can work on their manual dexterity in order to appropriately use a device they do have access to. Without looking at it more holistically, I think we'll continue to just sort of throw out lovely big ideas, but it will not bring equity to the table, which in the end is what we all really want.
So the digital vital sign, that sounds like a journal article waiting to happen.
Yeah, doesn't it?
So listen, I'm sure there's going to be a lot of people, Anita, that want to learn more about this. Is there a way, without kind of bombarding your inbox, that people could reach out and connect with you on this?
Yeah, I'm afraid bombarding my inbox is probably the best way. So I'm happy to connect with people that way. I think putting all our ideas together is probably best.
Can we share your email in the chat? Is that okay? Or
yes, you can. It's ramsetty@musc.edu.
So Sherry will throw that in there, because I'm sure people are going to want to learn more about that as it evolves and progresses and all of that. And who knows, maybe you get some feedback and enhances like your product development as far as your DVS, as I'm calling it now. Real quick, because we're going to jump into solutions now. And I just want to, I promised you guys, I wanted to remind you a little bit about what Revel Health does, our sponsor of today's program. They are a great fit for today because they work on behalf of health plans and accountable care organizations to take a very sophisticated approach to focusing on an individual's needs. So not entirely different from what Anita was just talking about. So if you've ever talked to the most accomplished Madison Avenue ad agencies, the ones that drive behavior change for the biggest brands that we all know and use, Revel, they take a much more like sophisticated approach to influencing our behavioral change than most of us do in healthcare. And that is only until now, because Revel Health is taking very much that same approach around understanding a individual's values well enough to truly influence how they could change their behavior. And so in healthcare, that is one of the sort of the keys to driving better outcomes, especially as we're thinking about the importance of social determinants of health and an individualized approach to that. So we haven't been that sophisticated until now. Revel Health is taking the highest cost patients for you and figuring out unique ways to communicate with them that drive change. So if you want to learn more about them, you could check them out at revel-health.com. They just merged with Novu. That's novu.com. So you can check them out on either website. I believe they're one of the new bright spots in healthcare, so check them out. I want to talk about now some of the key components to overcoming health illiteracy when using a digital platform. So Sara, with all your work you're doing with all your clients, what's the best way to be thinking about addressing this problem?
So first, I want to just kind of second Dr. Ramsetty's sentiments around the need for these really short and targeted surveys. What we found is that getting those done as early on in the patient journey as possible and updating them with measured frequency is critical to understanding people's orientation and also the changes that they're going through. These are very fluid things, and the situations shift. And so we need to keep on top of people and what's happening in their lives in order to be able to respond with solutions that are appropriate. The other aspect that I would comment on is, in order to overcome health illiteracy, what we have focused on in great detail is cultural orientation. How you speak to somebody, the phrases that you use, and the integration of cultural norms. There are specific ways to communicate, and somebody in the Northeast who lives in an urban environment may communicate very differently to somebody who is rural or on Indian reservation. So we need to be aware of how people are, their cultures, their norms, and craft communications and engagement strategies around that. There's also situations where people don't trust technology, and you have to know that. So it would be ridiculous for us to try and engage somebody in a pure digital solution if that's not the mechanism and the vehicle that they trust to communicate with their providers. And so really trying to craft that and drill down into this micro segmentation is critical. And I would give an example that recently happened. We were trying to engage a population in a very small area of the Bronx, and we just could not figure out why they were not responding. And what we actually noticed is that there was a high Polish population, and the communications that we were sending out were they couldn't understand, and there were much different ways of accessing care than what we were recommending or suggesting. And so we had to shift and pivot really quickly, understanding that this is something that we're not going to enable them to take the right action at the right time, the right place. One of the other components that I would comment on that we've been speaking about is, the need to get people to these surveys and to get people engaged. The other component that I've noticed is that there is a lot of regulatory action in this space right now, good and bad. So some states are incenting providers and health plans to engage patients in this way. Others are creating a more punitive approach. And so I find it interesting to see how this is evolving, because this is adding an additional cost burden in order to help solve for this. And for especially some of these community clinics, there needs to be a reimbursement structure, whether it's the state or some type of value-based arrangement where there is a payment structured around being able to deliver this. And so while it's slow to evolve, that's some of what we're seeing and potentially a bright spot to help encourage solving this problem.
You know, I'll lob this to you, Sarah, but anyone could jump in. I'll call it a jump ball, which is one of my cardinal rules of things not to do in monitoring, but I'll give it a shot here. One of our audience members, I think it's a great question or a great suggestion, is schools are dealing with many similar issues as well. And sometimes it's the kids obviously onboarding their parents with some of these tools. Can you partner with any of them, or has that been done?
We have seen that. It's not something that we're currently doing. There's a lot of social service organizations that are trying to do that, but we know that education level is so highly tied to health. And if we don't engage people in school and continuing to stay in school and access the technology, then they're going to fall behind. And that has also catastrophic healthcare consequences. And so we recognize that, we've spoken on it. It's not something that we've solved for or engaged in, but I think there's a huge opportunity to help partner with organizations like that and connect them to providers and health plans to start working holistically to get students engaged.
Yeah, I would completely agree. So here in Trenton, Henry J. Austin is partnered with our Trenton School District. We have a mobile health unit. And so we've been using our mobile health unit to visit schools, particularly at the beginning of the school year. We have an immunization drive that's going on right now. One of the unfortunate consequences of COVID is that many children are delayed on their vaccines. It's actually a national issue. And through that communication, we're actually doing exactly what Sara was saying, thinking about how can we ensure that children are healthy, but also receiving their education at the same time, not being isolated, receiving the behavioral health and mental health services that they need, because they're so intertwined, particularly since many children now have been impacted by COVID, and particularly since we were talking about the health inequities. Many children of brown and tan skin, we know COVID has disproportionately affected their families. So there's lots of intertwining between the education, mental behavioral health, wellness, and how they're doing in school. So again, working with our school district, trying to address those needs at the same time and do it thoughtfully.
These surveys that everyone's referencing, just real quick, yes, no, are questions tied to, are any questions tied to financial health as well? Yes. Okay. That's a question. Real quick, Sherry, I'm going to put you on the spot here. I remember we have access to an ebook called The Great Divide, and it's the byline is 5 strategies to bridge healthcare member gaps. And it's authored by our friends at Revel. And if you want a copy of that, why don't you we'll put up a poll. It talks about precision personalization in population health. It talks about perspectives on care and solutions to meet people where they are, and why partnerships are so important to doing that. So it really covers a lot of the things we're covering in detail. So if you want a copy of that, it's a PDF we have. I'll get it out to folks who just request it here via the poll. We'll also give you some contact information to the authors if you have questions or just want to pick their brains. Could be interesting for everyone. Kemi, let me keep you on the stand here. You're dealing with a lot of homeless in your market. So how are you reaching them, as well as the other, maybe they have homes but they're underserved, and how are you facilitating just digital care and telehealth in these unsheltered populations in Trenton?
Yeah, that's an interesting question. And I want to say I have dibs on Anita's digital survey, digital divide survey. So we'll be talking. This is awesome.
Panelists get preferences.
Interesting. So one of the things that's unique to Henry J. Austin is we have 9 locations. As I mentioned, one is the mobile health unit. So that does go in and around the city of Trenton. We have the 8 other locations, 4 sort of bricks and mortar, very traditional. But the other 4 are these primary care offices that are actually embedded within a mental health institutions and within a homeless shelter. And as such, we've been partnering with those institutions, as you can imagine, those individuals that have severe mental illness and those individuals that are homeless. And also a lot of times they're intertwined. Individuals that are homeless, one of the reasons is because they often may have a mental behavioral health illness or a substance use illness, again, complicating their whole chronic diseases. And so partnering with them, the homeless shelters and the mental health institutions has really been key. And one of the ways we've done that uniquely, I think, in the city of Trenton is this innovative collaborative we have called the Trenton Health Team. It was founded back in 2006, and it's represented by Henry J. Austin Health Center, our 2 local hospitals, the only hospital systems in the city, and our city Department of Health. And we come together on a regular basis, basically with the goal of making the city as healthy as possible. One of the initiatives that we worked on really early on was communicating between all of these entities in terms of the shared individuals we have. So we instituted a Trenton Health Information Exchange. And that way I could see whenever my patients went to the emergency room, and the emergency room physicians could see exactly the notes and the things we ordered within our health center. In that, we really identified some of these high-risk homeless individuals, and we would meet regularly and talk down to the very granular level of how do we help Mr. Smith? And it was the hospital systems, it was Henry J. Austin, and then through the Trenton Health Team, we also pulled in a lot of those social service agencies. So we pulled in the Homeless Alliance, we pulled in the Mercer County Social Service Department, we pulled in the Rescue Mission, the Salvation Army, so that everybody was really talking about an individual and how we help that person. But then we were also able to then improve processes and failures within our systems that were linked. And that was, again, a really unique opportunity that we've been able to capitalize in providing services to our homeless individuals.
Wow. I want to throw another follow-up, and this person gets the grand prize winner for best question from the audience. You win a pat on the back from me virtually. We should do a whole event on this, Sherry, so get this. What does digital equity look like? Right, that's a whole session, right? But could you maybe give us a quick 2-minute, what does it look like? Anyone?
I will. Oh,
Go ahead. Go for it, Jorge.
I'll jump in. I'll see. We'll iterate on it. This is a safe space. We'll iterate on it. So I think borrowing from some of the language of the health equity language, the way I've been looking at it is sort of for everyone to have sort of a fair and just opportunity to engage with digital tools is the way I've been kind of thinking about it. And part of that, in terms of more granular things, really involves kind of social changes. I think one of the big things that we can really push forward is universal broadband access, right? Just if we're really pushing towards making this a central part of the way we deliver care, having everyone be able to have access to the internet and be an active participant online, I think this is such an important piece of it. But I think simply put, I think for me is just everyone having a fair and just opportunity to engage with these tools. That's very broadly speaking, obviously. And then all the things we've talked about sort of fall under what that looks like more specifically.
Yeah, I think I would like to tag on to what Jorge said. And, for us, I think integral to CARES being a clinic that always seems to be struggling with our own funding, we're very cognizant to the fact that materials, access, all of those aspects that we like to think of broadly will not always be readily available. And even if they were, they wouldn't necessarily solve everything. So we by no means, and I think everyone on the panel would agree, we know that access alone will not solve this. And at least for us, a way of trying to get to this position of digital equity, for us, we're trying to tap into the power of communities and really trying to understand culturally and community-wise where everyone is coming from. So for instance, our rural outreach clinic is about an hour and a half or so outside of Charleston. It's about 39% of the families falling under the poverty line. very high rates of food insecurity, very high rates of chronic diseases of different types, diabetes, stroke, hypertension. And for this group, what we had planned to do, COVID threw us off just a little bit, but noting how strong the community ties were there, what we have been trying to do is to incorporate a model of care that has been referred to as barbershop medicine, where really the healthcare that is given out, there's more in centers where people gather normally, and where there's a really strong sense of trust, where there's a strong sense of connectivity to each other. So in terms of really truly getting to equity, we think it also needs to take into account where people find support and trust. And so in this model, we would embed devices or telehealth devices or access in a school. So one of our attendees asked, would you incorporate the schools? Yes. As it turns out, in St. Stephen, the two schools that are there, the middle school and the elementary school, literally are the heart of those communities. People are always there. And when we started asking, would you go to the school to check in on your blood pressure, your blood sugar, if there was a community device there? The answer was across the board, yes. And as healthcare providers, we always start thinking about all the red tape. So the first question was, well, what about your privacy? Do you want to go to a place where everybody knows you and you're putting all your healthcare information out there? And every single person we asked said, yes, this is a small community. We know each other here. We're here to support each other. And I think knowing that about different communities, it won't be the same for everybody. And even within the community, it might not be the same. But that is a particular cultural strength of that community that I think could be tapped into in order to raise the equity so that, yes, everybody would have access there. It just may look different than access in Charleston, which might look different than access in Trenton. And that's fine, as long as we get to that endpoint that Jorge pointed out, which is we all have equitable access to it, regardless of how we get there.
I see we have 5 minutes left, so I want to ask one last question to connect the physician to the patient. And incidentally, next week, 2 p.m. on Thursday, so the 29th, typically, we're going to be covering a cool topic called Innovations in Physician Engagement and Provider Learning, especially in light of the pandemic and how to keep physicians engaged and on top of their game with new treatments, especially around COVID, right? So David Nash at Jefferson College of Population Health, all of you probably know him. He'll be on the panel along with Mary Ellen Beliveau, who's the founder and CEO of Knowledge to Practice, as well as Dr. Daniel Davis. So join us for that. Sherry, I put a link to register if you want. 2 p.m. live recording on the 29th. Jorge, what about the physician, and how are you able to solve this digital divide so that physicians are engaged and able to do the best they can to provide the right treatments to their patients? So I'll have you jump in, and anyone else that wants to jump in can right after that, and we'll see if we can finish this up in the last 4 minutes.
Yeah, I mean, I think it's a lot of the work that everyone on this panel has been talking about. It's really setting up the kind of the workflow pieces and really connecting this with the fact that this is a standard part of the way we deliver care and can really benefit their patients. So I think at an organizational level, having that set up and physician buy-in and then getting their feedback is key. At sort of the one thing I always reflect on at sort of the more personal level is around what my role is as a physician as I'm sort of on the front lines, I'm approaching a patient, and there's some data to suggest that as clinicians or just in the general healthcare system, we make decisions on who we offer these tools to based on what they look like. And, you know, I always like to reflect back, like you can't tell whether someone's going to use telemedicine by looking at them, right? I'm not able to tell whether you have device access, we have internet by looking at you. So I think if we really deliver this as part of care, taking a step back and being like, you know, regardless of who's in front of me, if this is a standard part of care, I'm going to offer that and have that conversation with the patient and not make assumptions and say like, well, they're not going to use, I don't think this person's going to use the portal, or I don't think they're going to engage in telehealth, or they probably don't have internet. I don't know I don't know where this patient's like. That's why you have the conversation. So I think those are the two pieces I like to think about. And I think that the last piece, funny that you mentioned sort of like kind of, you know, clinician education. I think that the other piece that's important to reflect on is the fact that, like, we talk a lot about patient-facing digital literacy, but there's a big component of clinician digital literacy that comes into play, because this is such a change in the way we deliver care. Being able to navigate and feel comfortable with some of the tech tools in front of us Even from a physician side, I just remember like the first time I've joined a new hospital and working on their electronic health record, I'm all sorts of confused and I'm concerned I'm missing something. And similarly, you have that experience when you're picking up telehealth. So I think there's some component where like you have to address patient digital literacy, very important, but there's also that clinician side that's important to address.
So, anyone else want to jump on there and end things off for us? Okay, I have a bunch of other questions, but I know with 2 minutes left, that would be a bad move. We'd go way over. I want to be respectful of everyone's time. For all of you who are listening in and watching live, we don't take the 60 minutes of your day lightly. We really feel privileged that you took the time with us. So thank you for being here, and hopefully to continue to engage with us. Please provide us that feedback through the feedback form so we can continue to drive the right content. I already see a topic on what does digital equity look like, and as well as Jorge, overcoming implicit bias in healthcare delivery. I think that would be a cool topic. So two topics from you guys already. Great job. Thank you to the four of you. The time you took to prepare with me, the time that you took today to provide all this great content, I really, really appreciate it. Thank you to the team behind the scenes, Sherry and friends, for putting this together. This will mark the end of the show. Guys, stick around for a second. I'm going to stop recording. Thanks again. See you next